Good morning, distinguished colleagues, ladies and gentlemen. Picture a Malaysian in which every outbreak investigation, vaccination campaign and policy briefing is led by a doctor trained to exactly the same world-class standard, no matter which university they attended. That is the promise behind our journey to standardized public health medicine training. I'm Professor Dr. Victor Ho from University Malaya, and over the next 15 minutes, I will take you through 4 chapters of our journey: how our training evolved, the challenges we confronted, the National Postgraduate Medical Curriculum or NPMC that unify our standard today, and the new competency we must cultivate for tomorrow's public health workforce. I would like to thank the College of Community Physicians of Sri Lanka for inviting me to the Global Public Health Summit 2025 in conjunction with the 30th Annual Academic Session of CCPSL. I would like to acknowledge the Asia Pacific Academic Consortium for Public Health for the opportunity and recognition for me to share my views. Chapter 1 began 7 decades ago. In 1953, the World Health Organization support the University of Malaya, then located in Singapore, launched a diploma in public health to build sanitary services for young nation. Fast forward to 1973, Malaysian Cabinet approved a 1-year Master Public Health Program, or MPH. The first cohort of 7 doctors graduated in 1974, ready to serve as medical officer of health across our expanding rural services. Those early steps laid the academic cornerstone for today's public health medicine specialist, or PHMS, pathway. They answered a simple but profound question: how do we translate population science into frontline action for Malaysians? Chapter 2 tracks our milestone. In 1980s, leadership and health management modules were woven into NPH, and new programs emerged from University Kebangsaan Malaysia and University of Science Malaysia. Between 1992 and 1999, we piloted a 4-year MPH Plus specialty track. The first 9 specialists graduated in 1999. 2006 was pivotal. The National Specialist Register, or NSR, officially recognized public health medicine as a clinical specialist. 2009 saw University Malaya roll out the Doctor of Public Health, or DRPH, nurturing advanced leadership and system practice. Finally, in 2021, the first tranche of National Postgraduate Medical Curriculum document was released, setting the stage for a single national blueprint. What does accreditation look like today? The Malaysian Medical Council governs the NSR, and since the medical regulation of 2017, registration is mandatory for specialist practice. To qualify, a doctor must hold a minimum of Master Public Health plus a Doctor of Public Health, alongside supervised field experience documented in a logbook. As of March 2023, we had 870 registered PHMS, 74% served in Ministry of Health, 16% in public university, 2% private practice, and the rest in armed forces and other agencies. Recognition is crucial, but consistency is just as vital. By 2020, Malaysia boosted 10 universities, several parallel pathways producing medical specialists, each with different curriculum, assessment, and field requirement. Imagine a patient unable to distinguish between 10 versions of the same vaccine. Variability undermines public confidence in specialists. 2. Stakeholders from ministry to professional colleges agreed we need one competency standard. That consensus paved the way for the National Postgraduate Medical Curriculum. So, what is the NPMC? It's a joint initiative by the Ministry of Higher Education, the Ministry of Health, and the Medical Dean Council. Released in 2021 for the first 12 specialists and drafted for public health by mid-2025, it offers one competency-based template applied uniformly to every training route, university or parallel. The curriculum delivers policy muscle because it carries endorsement of regulators and educators. For public health medicine, NPMC backbone is simple but robust. Structure: Part 1 is a 1-year coursework and research. Part 2 is a 3 years of supervised field placement, research dissertation with a 10-year maximum window to complete. Competency: 7 domains from clinical, public health practice and population health assessment to policy development, risk mitigation, communication and professional ethics. Supervision: academic trainers at the ratio of 1 to 6 candidates, field supervisor 1 to 2, and every trainee must be a national NSR registered and train the trainer. The result: clear milestone, transparent feedback and nationally portable qualification. Alongside the NPMC sits the Speciality-Specific requirement or SSR. Think of the SSR as a technical annex. It stipulates minimum curriculum content, trainer credential, facilities and assessment method. More importantly, it aligns our rigor with global benchmark from the UK Faculty of Public Health and Australian AFPHM and Europe's UEMS. That alignment builds international credibility and eases mobility of our global graduates. But standard cannot stand still. The curriculum now embeds 4 emerging horizons: digital health, from outbreak dashboard to AI-driven contact tracing; climate and environmental health, including vulnerable mapping for heat wave and flood; health equity, ensuring policy reduces, not widen disparity; system thinking, so graduates can navigate the complex interaction of policies, economies and behavior; field epidemiology, big data analytics and disaster response skills are now essential learning activities. Vital lesson from COVID-19. Let's talk numbers. Our target is 2.5 public health medicine specialists per 100,000 population. To achieve that, we need 859 public health medicine specialists by this year, 902 by 2030 and 939 by 2035. Current projection forecasts a shortfall of roughly 150 specialists in 2025 when retirement are factored in. Scaling up training intake alone will not suffice. It must mesh hand in hand with robust accreditation to keep quality high, especially as the average number of diseases outbreak has clinched 6.7 per annually since 1980s. Allow me to summarize our 4 chapters story in one sentence. Malaysia has moved from fragmented programs to a unified outcome-based system that strengthens specialist credibility, mobility and public trust. Yet our work is ongoing. We must now weave planetary health thinking, digital surveillance and regional mutual recognition agreement into a fabric of training. Success will hinge on collaboration of educators, service providers and professional bodies, and on the commitment of each trainee to embody this standard practice. My thanks to the Ministry of Health, Ministry of Higher Education, the Malaysian Medical Council, the College of Public Health Medicine, and international partners like APAC for driving this agenda forward. I will close with one question to you. Which competency, digital health, climate health or health equity, do we believe will shape our discipline most in the next decade, and how can we embody it swiftly into training? I look forward to your thoughts, and thank you.